So just like you've heard now a couple of times, transposition of the great arteries specifically is one abnormality, but throughout history we've actually made it into two different abnormalities depending on whether a patient got a mustard and ascending or they got the arterial switch. And as I said in the beginning, cardiac MRI is really great for assessing ventricular volumes and myocardial mass. And so cardiac MRI has become really a great way to assess these patients, along with the strain that Dr. Friedberg just told you guys about, in assessing the patient's ventricular volume and how well it's working, the right ventricle versus the left ventricle. So you're going to have two different anatomies now because of the different surgeries that have happened. And you got the arterial redirection, mustard ascending, or the arterial switch. So here's the anatomy. The one in the middle is the atrial switch or atrial redirection. And the way I was sort of taught to think about it is it's sort of like a pair of pants with the belt of the pants being around the mitral valve, and then the two legs of the pants each being one the IVC and one being the SVC. So the pants are receiving the blood and then going across the mitral valve and going into the left ventricle, taking the systemic venous return. And then you've got an obligatory ASD that's behind that baffle that's letting the pulmonary veins come into the right ventricle, making the right ventricle the systemic, or keeping it as the systemic ventricle. All right, so that's going to allow that vein. And because of that, there are many different locations where stenosis can happen, or leaking can happen, or abnormalities. So we heard a little bit about the transposition of great arteries. The incidence is about 301 million. You've got the Senning and the mustard in the 1950s and 1960s, and then the arterial switch in the 1970s and 1980s. And obviously the Rastelli operation that Dr. Silverman mentioned when you have the PS. Just a little bit of why we do the MRI. I think we've talked about this already, the biventricular function, the measurements, pulmonary and aortic valve stenosis and regurgitation, and then assessment of the IVC and SVC to see if there's any baffle leaks, and the pulmonary veins to see if there's any stenosis. So here's a patient where you can see that they still have the sort of the pathognomonic sign that we talk about, where you have the aorta and the pulmonary artery are parallel rather than crossing. We talk about this a lot also in neonates, where you're going to look, especially in the prenatal period, that you've got the crisscross of the pulmonary and aortic, and here you see that there isn't, and you see both of them in the same plane parallel to each other. Here you're going to see the pulmonary veins coming into the right ventricle, a systemic right ventricle. It's hypertrophied and thickened, and here's your left ventricle that's operating under pulmonary pressures, lower pressures. But one of the things that happen is you get dyskinesis of that septum. And here again you see the SVC and IVC, that's the baffle I was telling you about, around the mitral valve into the left ventricle and up to the pulmonary artery. So we can see that by that twist mechanism that I was telling you about, where you see the angiography entering, and I've labeled this for you to help you through. You see the SVC getting the contrast, and then enters the left ventricle and out, I think the pulmonary arteries, and then you got to see it into the pulmonary veins and into the aorta. Same thing with a patient, you can see a little bit further, and then you can look at the images to see how you're assessing it and whether you've got any pulmonary valve abnormalities with that. You can look even further to see, the pointer is not working very well, but you can see the IVC and SVC and assess them to see if there is any stenosis there. You can also look to see if there's any abnormalities, specifically with the outflow tracts, and see if you're going to see anything from that. And lastly, you can look at the SVC and IVC in this patient right here. You can see the SVC had been stenotic. They went to the interventional catheter location, and you got a stent placed, and then you can see that the SVC is now widely open. And then you can see obstruction both in the IVC with azygous continuation through that as the pulmonary veins are returning in a retrograde fashion. The pointer isn't working. Here's actually a cine image now. You're seeing the function specifically in the bottom row on the third column. You can see that the image is not so crisp. These patients begin to have sometimes PVCs and other abnormalities that happen, and so you're going to get not as nice of images potentially in the MRI. In the top image, in the first row on the second column, you can see that right ventricle is very hypertrophied, it's thickened, it's not its normal shape any longer, and you can see the left ventricle is not getting to open up and be as useful as it would have been normally. We had a mention of the single coronary artery, and we do continue to see that in them. The CMR after cardiac magnetic resonance after atrial switch, and now the goal for the atrial switch is very different than the goal was for the arterial switch. The arterial switch, you're going to look at the right ventricle, you're going to look to see how it's functioning, and you're going to look at the baffles. With the atrial switch, you're really going to look at your coronary arteries that were reimplanted, and the other thing that you're going to look at is you're going to look to see if you have any delayed enhancement abnormalities that could be caused by a coronary artery ischemia that may have happened at surgery or shortly after surgery. You're also going to look at the pulmonary artery much more closely because you had those buttons that were removed, and you frequently can get pulmonary valve stenosis just above that. So here's a patient that had the arterial switch, and what you're beginning to see up here is pulmonary valve stenosis, and you can see that the right ventricle is thickened and is working under high pressure. You can see that much more clearly here. You can see the flow artifact that's happening as the pulmonary valve is opening right at the pulmonary valve, but superiorly it's not opening as well. You can see that again in short axis in the image on the right side, and you can see the dilation actually of the aorta. And you can see here that the pulmonary valve is actually in the Lecomte maneuver that Dr. Silverman described to you guys, where the pulmonary arteries have been moved in front of the aorta in order to prevent them from getting stenotic. So here's the pulmonary valve. You can see the stenosis that's occurring there, and I will show you guys also that happens. The branch pulmonary arteries get stenotic. Here you see the right pulmonary artery and the left pulmonary artery. You can see the flow through them. And then you can see the Lecomte maneuver. The pulmonary arteries are really, just like Dr. Silverman said, straddling like a horse around the aorta. And this specific patient happened to have actually right pulmonary artery stenosis, which at baseline doesn't look that bad, but then when you exercise the patient and you've got increasing SVC flow and increasing aortic flow, it actually squeezed the right pulmonary artery, and during higher cardiovascular needs, she actually had almost no blood flow going to her right pulmonary artery. You can see that same thing in cross-plane again, and you can see how small and slit-like that pulmonary artery becomes. You could also take a look by twist at the images. You can see the pulmonary arteries. In this specific image, I don't know since this isn't working, but you can see that the right pulmonary artery's got a small location in it that is kind of pinched, and you've got less contrast entering in that. I'm going to skip this just for time. This is again the coronary artery low resolution that I was showing you guys earlier. And you can look at the coronary arteries. Here is a patient that has normal coronary artery anatomy. You can see it's nice and patent and doing well, versus abnormal coronary artery where you've got the circumflex coming off of your left anterior descending. This is the late gadolinium enhancement imaging that I was telling you about earlier. This is where we're looking for myocardial fibrosis, either by ischemia, or in this case, it's not true ischemia, but obstruction that happened in the coronary arteries because they were moved. And what you see here is you're looking again for that donut that I was telling you about, And in this case, you see where the two arrows are pointing, that the donut's got, instead of being nice and black, you've got subendocardial ischemia that happened from a coronary artery abnormality. So just as I showed you guys, you can look at the different volumes and those sort of things. Now just briefly, I'm going to show you guys a couple of images of left transposition of the great arteries. More than anything else, I think this helps sort of visualize where it is. Again, you're looking, the aorta is the circle right here, and then the pulmonary arteries are the branches right here, and you can see they're in the wrong location. You normally would see the aorta here and the branch pulmonary arteries crossing right over there. And so you've got the L transposition. And then when you look at the ventricles, they're actually up, down, rather than side by side. And you can see the abnormality of the septum. It's a flattened septum that's happening here. And you can see that the left ventricle is here on the bottom with the two papillary muscles, and the right trabeculated is up here. On this side, you can see the tricuspid valve going into the right ventricle and then joining into the aorta. And then when you do the twist images, you can see even the shape of the left ventricle being more of a bullet shape and the right ventricle being more triangular as you see the contrast entering and going through the ventricles. And that's about it.
To a little life-taking